All right, hello everyone. We are going to talk about medication safety in the community pharmacy setting today. First off, I want to start with a story. This is a medication bottle that, if you notice, has part of my last name on it, but that name in the front is not mine, it's my dad's. So this happened back in 2015 or so, I believe, if I'm not mistaken, before I got into teaching this. But this was a misfill. So my dad actually noticed that he was urinating more, and he said, Daniel, I wonder what's going on. And so I said, I don't know. Did they change your medication? And he said, No, I don't think so. They didn't tell me if they did anyway. And I said, Well, what are you taking? And he said, I'm taking Hyzar. The brand name of this is Hyzar. And he said that he's taking the same dose. And I said, just on the off chance, take a picture of it and send it to me. And so he did. And this is what I received. And so I said, okay, I totally understand what happened here. So this was a misfill. He got more of the diuretic than he was supposed to. He actually doubled the diuretic than he was supposed to. Obviously, it's not something that was going to be a complete life-changing event, but it was something important nonetheless to bring up because he couldn't keep taking it. This isn't one of those things where he got double the dose and then he could just take half of it and get away with it. He would have to get a new bottle of medication. Well, he was at the beach. Coincidentally enough, this was in the summer, and he was in Daytona Beach. And so I said, well, take it to a local CVS and tell them what happened. And they should give you, they should fix it and they should give you the new bottle. Unfortunately, they did not. I had to call the pharmacist there and tell them who I was, that I worked for CVS, and that they should be ashamed of themselves, dot, 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 dot. Who was their district leader, blah, blah, blah. Well, they changed their tune right away, and my dad got the correct medication. But it was almost kind of embarrassing. At that point, I'd been with CVS for 15 plus years, and I'd seen this plenty of times before because this was just a label on the bottle, so it wasn't like they had to count it out, and they could have gotten another check on it, but it was still something important. This was one of the things that pushed me into being interested in med safety as much as I am now, not because it was that significant, but honestly because it wasn't. This was something that could have been a lot worse and had a lot of fail safes that the system didn't catch. Obviously, they didn't barcode scan. They didn't do product verification correctly. There's a lot of steps in the process that were either skipped or were not taken as seriously as they should or could have been. All right, so that being said, here are our objectives. So we're going to talk a good bit about the strategies and problems that can occur. Sorry, the problems that can occur in medication safety, specifically in the community setting. Although, as we've discovered throughout the quarter, there are a lot of times where this overlaps. It just does. There just isn't any other way around it. It just does. We're going to talk again about the DSCSA, and that's something we're going to come back to again. We're going to talk about drug storage, drug labeling, drug packaging, environmental factors, patient education, that type of thing. The basis for this, or the core of this, is around this 2009 report called Improving Medication Safety in Community Pharmacy, Assessing Risk and Opportunities for Change. I'm not sure who the ISMP's graphic designer was, but this is straight out of whatever era that was, and maybe they were a holdover from previously only using like Microsoft Word Art or MS Paint or something like that. It looks like it's from before 2009, but I promise you it's not. It's from 2009. Now, why are we using this? Is there something better? There are other documents that we will look at as the quarter progresses that are from ISMP that have different information in them, but this was what's called a white paper, which is like a guidance document that has a lot of information in it that's really, really helpful. So, as we talked about before, ISMP is the nation's only nonprofit charitable. Charitable just means not for profit, and gives away or uses and spends its revenue on things that benefit its target population. So in this case, they issue grants. They fund organizations that deal with medication safety. That's what their charitable status is. It is respected and known worldwide. It is a very probably ubiquitous organization. All pharmacists, if you talk to your preceptors, say, "What do you think about ISMP?" They pretty much know what it is. All right, so let's focus in on community pharmacy. So where do we come from here? Each year in the United States, 7,000 to 9,000 people die as a result of medication error. This is from the Error to Errors Human Report in 1999. So the data are not as consistent as we would like them to be because the definitions aren't as consistent as we would like them to be. For example, if someone has a heart attack due to being underdosed on, let's say an ACE inhibitor, that's going to be very difficult to catch, particularly because they might have other risk factors. Let's say that they were also obese. Let's say they were also all these other things. That's going to be very difficult to catch. The cost of looking after patients with medication-associated errors exceeds 40 billion each year, and then in the community setting in particular, there are 4 errors per 250 prescriptions per pharmacy per day. They don't have to be big errors. They could be small errors. They could be errors that are caught. The whole point is that we catch the errors. That's what I was talking about with the prescriptions for my dad. The intention is that we catch these things when they happen, because if we catch them before they leave, then the patient doesn't get harmed. It might harm our egos a little bit, which is a cultural issue that we'll talk about a little bit today, but on into the future. That's a problem that we might be ashamed to commit an error. But pharmacies that fill 2,000 scripts per week have up to 2 clinically significant prescription errors per week. All right, so terminology review. This is straight from the Foundations lecture. I don't want to repeat it out to you, but it's something that we're going to come back to this lecture. So here is this slide. I literally copied and pasted the slide. ADE, ADR, preventable ADE, non-preventable ADE. So remember what we talked about with information availability is really, really critical here. So I gave you the example of when I developed hives this past May. I was scared. I was in the middle of nowhere with my family at our house, my mom and dad's house. I was terrified. I did not know what was going to happen next. I did not know if I was going to make it, because I know that anaphylaxis can be unpredictable. That was not a preventable one because I had no clue. I, as the patient, even had no clue that I had a history of this or that I was at risk for it. So that if it was to go back and be coded, it would have been a non-preventable ADE because it was drug-induced harm. So all right, so the path of a prescription. So this is from that 2009 document here, this is from a different document. This is from a root cause analysis workbook for community pharmacy. But I like it because it's a flow, and that my brain kind of works like that. But what it is it says as soon as the order is received, then we triage it. And that's true, we do. Whether it's the pharmacist triaging it, the technician triaging it. So let's say if it's a paper prescription, which are pretty rare, but they exist. We have a process for trying to figure out whether or not we need to do anything about it before it goes any further. So in that triage step 1, we decide if we want to call the patient or call the prescriber, meaning like if it's dropped off or if it's sent over. What if it's something that is not covered immediately, or if it's something that is just really incomprehensible, we might call the prescriber. If it's something that's expensive, we might call the patient, because if we don't want to have to order it and send it back if it's something that they don't want. So we go back, and it kind of circles back to the beginning. Then we go to order entry, which is step 2. And so this is where there's a little bit of variability depending on what chain you're at. So if you have 2-step verification, which CVS does as of a couple of years ago, we used to only have 1-step verification. I'll talk about what that is in a bit. But we call this order entry verification. So basically prepares the medication to be produced. So it says, okay, this prescription was for lisinopril 20, number 90, one every day. So that's cool. It's by Dr. Smith. You know, it's 5 refills. Everything's good. Everything's good to go. No issue. So the label, so the label prints. We select the stock. We then verify that the produced prescriptions is step 2, or as we call it at CVS. And again, this is just speaking from my experience. We call this production verification, or step 2, or however you want to view it. I know Walmart has a different terminology, Walgreens has a different terminology, but they all basically do something similar. And it's the 2 biggest roadblocks are preparing right before you prepare the drug for production, or right before you produce the prescription, and then after you produce the prescription. And so again, if there's an issue, then it cycles back. So let's say I'm looking at it, and in the example of my father's medication, it was supposed to be for Hyzar, or the losartan hydrochlorothiazide 100/12.5. If I was doing my order verification correctly, I would have looked at it, and at CVS it says drug not scanned, accuracy scan bypassed. So I would know then to look real close at it, and then I would see that it was the wrong drug. So what you're supposed to do, and what I hope happens, is that you send it back so that you can do rejection at QV2, which is what CVS calls it, and you can send it back and you can say wrong drug. And then you can go and talk to the technician or whoever produced it and say, why did you not scan the bottle? And there may have been different reasons, but then it's an opportunity to coach and reinforce that you really need to scan the prescription, the bottle each time. So there we go. That kind of ends it. So one of those questions, it's hypothetical since this is a recording, but if this is different than what you're familiar with, how is it different? And then are there analogies that are similar enough to make it make sense to you? Basically, if you're one-step verification, you cut out kind of this middle part here. You might just have a prescription that is all the way produced, and then it's verified. And you can kind of see, hopefully, that if you've already verified a prescription and you have to fix something at order entry, then you almost wish you hadn't have produced it, because then you have to unproduce it, which is usually like a return to stock or something like that. You have to make sure then the drug is right, because you've already counted it out if it wasn't something that was a stock bottle. And then I want you to think about, are the differences between what you're familiar with, or what your institution or your IPI site does, are the differences meaningful in relation to errors and error prevention? Specifically then, is there something that most places are not doing that could be very helpful? That's actually something that is very insightful, because if we'd only make changes as a profession whenever there's enough, what's called like momentum, or political capital, or something like that. As we've discussed before, the government in our society really only makes changes based on huge controversies. That's just been our history. However, hopefully we're not sentenced to that. That's not the only way we're ever going to make changes. So that's something to think about. All right, so this is how we're going to structure today. We're going to talk about the 10 key elements of the medication use system that are relevant for community pharmacy practice. I've got them all listed out here, but I won't read them to you because we're going to cover them each in sequence. So we're going to start out with KE1, which is patient information. So a lot of the contributing factors here have to do with that gap really that exists between what is known about the patient, meaning I know it when I need to know it. Let's say that it's something where I don't have any information in the system that the patient has a penicillin allergy. They know it, but they didn't say anything to anybody, either at the provider's office or at the pharmacy. Then it's not really known, even though the patient knows it. So that's kind of a weird thing to think about, but it's very true, because that's why it's super important to, as patients, we talk to our patients about, let your provider know all of your medications, even if you're not like super thrilled to let someone else know. A great example is like the PDE5 inhibitors, sildenafil, Viagra, Cialis, all that type of stuff. Back when these first came on the market, there was a lot of push. There's a big marketing push. there's also a lot of like stigma around it, and I hope that you all have learned at least partially so far that there are a lot of drug interactions with those drugs, particularly drugs that are also used for cardiac conditions, meaning if the patient has a history of heart issues such that they're using nitrates, they are contraindicated from using these. Well, erectile dysfunction and heart disease also, exist in a lot of the same people. So there were a lot of deaths that happened when these drugs first came on the market due to patients not being upfront about what drugs they were on. And so that's not what you want. That's obviously not desirable, but it's something that nevertheless is something we have to keep an eye on. So another, you can read through these yourself, but these are all things that are about the gap that exists. So if there's some information that would be helpful or relevant that is not known. Demographics. So generally we're pretty good, especially in the e-prescription age, of collecting a lot of demographics. I'm always surprised, and I don't know really surprised is the right term, but when I look at the order entry side of an e-script, it just has so much information on it. It's oftentimes very difficult to parse through. Sometimes there is information in there that I'm not sure what it is, and I don't know if I'm just not knowing what I'm seeing versus if it doesn't really exist in the form that it should. So for example, was a provider aware of this allergy? Well, now that the provider can actually sign off. It says, verified by prescriber, and it gives like a name and data, name of prescriber or provider, and a date stamp of when they signed off. Like, for example, patient has a prednisone allergy. This happened last time I worked. Patient had a prednisone allergy, and then the drug that was prescribed was methylprednisolone, a Medrol dose pack. And when I came through, it popped because those are very similar drugs. And I looked at it, and it said, prescriber signed off. Well, our system doesn't allow us to enter through, which I think is great. It doesn't allow us to rely on that. So I still had to go ask the patient, did your provider talk to you about the fact that this drug is very similar to prednisone? Yes, he did. Is that an issue? That's what the patient said. And I said, no. I just wanted to make sure that everyone was on the same page. The patient was very appreciative of that. It actually made us kind of sound good, sound like we knew what we were talking about, which doesn't always happen. So that's kind of interesting, just a corollary to the way that e-prescriptions are sent through. There's a lot of robust information that's captured there. I'm remembering back in the day, there were these just static, paper prescriptions that were just existing there in 2 dimensions. There isn't really, I didn't know that they talk to the patient about anything, but there's a lot of information that comes over in e-prescribing. Another caveat, and I just have here, 29% of prescribing errors are associated with inadequate patient information, and that has to do with all of the things that were listed on on this previous document here. You can imagine there's a lot of information that's there, so it makes sense that most of the prescribing errors, or at least a large plurality of the prescribing errors, are associated with inadequate patient information. So here's another little caveat. I'm not sure if you all have seen third-party prospective DUR. It's a big thing that pharmacists do. It's one of the value-added services that we have. It takes all of the records. So it takes, if you get prescriptions through, your insurance company, then even if you get them from Walmart or Walgreens or Costco or whatever, then your third party knows what you're taking, even if the pharmacy that's filling it doesn't. Sometimes we see rejection messages there because, let's say that someone is in the doctor's office and they say oh, do you want me to send it to, you want me to send your prescription to the CVS that you normally go to? And they're like, yeah. And then they get to talking about something else, and then they come back around and say, actually, no, doc, I'm sorry. Can you send it to the Costco that's over here? That's going to be really closer to, on my way home, and I've gotten prescriptions there before. If the provider doesn't remember to cancel the prescription at Costco, sometimes it even requires a phone call, but a lot of times they can send a cancellation request, then the prescription is going to be filled at at CVS. And then when Costco tries to fill it, it's going to get a rejection message. If you're lucky, as the Costco pharmacist, it'll say prescription filled at CVS, number 9504 or whatever. Then you can call them and have them back it out and explain it to them. But you don't know that background I just gave you about like, oh, I was on my way home. You don't know that, and so it's really just kind of we're kind of stuck in this information limbo. I've seen duplicate paid claim or something like that before, which is not that helpful. So yeah, it's just really kind of interesting how these things work out. Another, I have a pregnant woman silhouette here to remind me to talk about this because as a male, I will just, plainly admit I very seldomly in public, and I mean actually never in public, amongst, social crowds, will ask a woman if she's pregnant. It is, there's lots of memes and videos and TikToks about it and everything, except that I have to here because a lot of these things, especially related to things like retinoids or ACE inhibitors and stuff like that are very commonly used drugs, are truly contraindicated in pregnancy and then in nursing as well. So one of the challenges with the third party DUR information is that they have like pregnancy as a status. So like pregnancy 1, non-pregnant 0. When someone delivers the baby, it takes a while for the systems to update that they're not actually pregnant anymore. They might be nursing, but they might not be. And then even if they are nursing, and you'll talk about this in therapeutics and things like that, there are drugs that are excreted in breast milk, and there are drugs that are not excreted in breast milk. And then there are drugs that are potentially toxic, but we don't know. There are drugs that have been proven to be safe in breast milk, and there are drugs that are proven to be toxic to infants and pass through into breast milk. So I always swallow my pride, walk over, and say, "Hi, I have a question for you. Are you pregnant?" And sometimes it's obvious. Sometimes when I see them, I can tell. Sometimes it's not though, and so you kind of have to like figure out how you're going to handle it. But it's really, really important because if you don't, that could really induce errors. All right, so risk reduction strategies when you receive the RX prescription. Ask for allergy information at each visit. Ask for the condition being treated with each new prescription. A lot of providers have gotten to the point where they're including the 4 or whatever, like even on like a lisinopril or something like that. They're 4 high blood pressure or something like that. And honestly, that might be for the patient more so than anything else. I remember back in the day when I first started, I would have to write on some of these really older patients, I'd have to write 4 blood pressure or 4 cholesterol or something like that on either the bottle cap or something really close to it. So it's helpful if the provider does it. Sometimes though, there are drugs, I'm thinking like an antipsychotic, so something like Seroquel or quetiapine. That's used for a lot of different conditions, even approved conditions it's used for. So, and given the sensitivity of the drug class, it can be difficult. So the way I handle it is I generally say, what did the doctor tell you that you'd be taking this for? Or what did you and the physician or the provider talk about? Contact info, so always great. I know CVS is really notorious about making sure that everyone's contact information is as up-to-date as possible. They don't really do it for safety though, they do it for extra care. But I'm still going to say that it's a good strategy. Telephone blanks. So one of the things that from a checklist standpoint, checklists are really powerful tools to help us not forget things. So if you think about a verbal prescription blank, technically, you don't have to have a blank or a prescription pad to write a prescription other than controlled substances in Kentucky and a few other states before e-prescribing. But the blanks for the providers and the blanks for the pharmacists taking verbal orders have a checklist idea in mind, meaning that it gives you spots to put everything so that when you are talking, let's say you're taking a verbally, there's a line for refills, there's a line for address, there's a line for phone number. You ask for all that information. Otherwise, you'd have to remember it as you're going along. And our brains don't like to do that. One of the other things about patient identifiers, so at CVS, we require either name and date of birth or name and address. A lot of pharmacies may have, again, one or the other thing. I think Kroger is preferencing address. CVS preferences date of birth. That can all those things can be tricky because you, especially with some juniors and seniors and thirds and things like that, or people with very similar last names. But I think one of the things that can be harmful or potentially harmful is when you are taking a verbal order. Let's say I was taking a verbal order for John Smith the fourth, but the provider didn't say that. The provider gave me John Smith and then gave me a date of birth. I would have to assume then, if I look in my system, that the John Smith the fourth that has that date of birth is the correct one. But it really is an assumption because they could have gotten the date of birth wrong just as much as I could have. So in those situations, I generally flag them or call the patient to make sure. Sometimes they call anyway because they were waiting on something. But those are just kind of niche situations. But it is relevant to think about how are we going about asking these patients for their identifiers, at what stages, and who we're asking for it. Are we asking the provider to verify the date of birth, the phone number, that type of thing, so they know that they're talking about the right person? All right, some order entry risk reduction strategies. So document. Properly code allergy information. So there is a difference between, obviously, unknown, which means you don't know, and then no known drug allergies. So even though those are both no drug allergies as a result, one of them means you don't know. So there could be drug allergies. One of them means that you have verified that there are no drug allergies. Hope that makes sense. I won't spend too long on it. Inquire, so ask. Have a hard stop for allergy information if the patient is not present. A hard stop at pickup. CVS's new smart DUR system. And again, I'm not advertising for CVS here. I just work there. And I've worked there for almost 25 years. So I know that area. But now CVS has a smart DUR system, so you can do a hard stop at the register, which will require the pharmacist to go over to the register, stop what they're doing, go over to the register, and it will prompt with information that they need to either ask the patient for or provide to the patient. So that's something I think is very helpful. It was annoying at first, but I totally see the value of it. Profile. I don't really see this as much anymore. I think one of the challenges with like flu shots and things like that is because of the way we bill their prescription insurance or Medicare Part B for influenza. So like when a patient comes and gets a flu shot, we have to make a profile for them. So that just introduces a lot of errors because especially if we're high volume, we might not have the kind of manpower to make sure we're doing all that correctly. I have not seen a case where there's multiple patients per profile. The only exception to that was for pets, and I think it was like a pet that was a twin, like two animals that were twins, and I don't know. I fell into that situation, and I don't even understand it to this day. But just know that that was part of the recommendations from this 2009 document. And then it's best practice to have a system in place for at least annual updates to patient demographics. I typically use every interaction, and I think CVS does this too, again, for extra care reasons. But it has double purposes. So we look and make sure the address is correct, the insurance is updated, the phone number is updated, we sign them up for text messaging. Again, that gives the patient more convenience. And then everyone kind of wins. All right, I mentioned DUR before, and so let's talk about that for a second. For appropriate therapy, what DUR looks at is that, so it's drug utilization review. It's looking at a lot of things, but these are the main things that are important to us. It's making sure that the drug prescribed matches conditions. So if there is something on the patient's profile, if there is a drug that is they're already receiving that has the same indication for what they're doing, we want to make sure that that is an appropriate add-on therapy. So for example, it is appropriate to in certain patients to use an ACE inhibitor and a calcium channel blocker for hypertension, but not all patients, and certainly not with them unaware of it, certainly not with the provider unaware of it. It could be appropriate to switch the patient. Maybe that's what was intended. So that's a challenge. So we need to make sure that we are on the up and up and that we are making sure that the drug matches the condition. Correct dose. We make sure, and this is really relevant in chemotherapy and in pediatric patients, that we're making sure the dosage is appropriate for age and weight. But I think obviously geriatric patients, older adults, they're very sensitive to dose variations. A good example that comes off the top of my head is in Zolpidem, so Ambien. One of the things that came out, honestly, probably 10 years ago right now, is the starting dose of Zolpidem, the max dose of Zolpidem in older adults was dropped to 5 milligrams. That really hurt a lot of people, because what happens, it's eliminated in such a way that it hangs around for a while in older people, and so they were getting progressively, lethargic and things like that during the day, which is of course a falls risk. So I had to do a lot of education about that, and a lot of angry people, as you might imagine. I already mentioned the duplicate therapy part, and I'll make another plug here for CVS, because I do think this was a big advancement that happened a couple years ago. When we go over there, typically for a dosage change that isn't obvious, sometimes there are things in the notes section of an e-script that says like DC lisinopril 20, start lisinopril 40, which is very similar to the way orders are written in a hospital setting, which is really good. I wish they would do that more often. Sometimes they don't, though. They'll just send over lisinopril 40, and so then I've got 2 drugs there. I often fill in, so I sometimes don't know immediately what drug has already been filled, what drug is the new drug, because it may be a refill of an older drug. Maybe they dropped the dose, Maybe they used to be on lisinopril 40, and now they're on lisinopril 20 instead of the other way around. So what we can do is we can put a prompt at the register, again, one of those forced DURs, or one of those forced counsel, and we can ask them, what's your current dose? Well, let's say in that example that the last thing I said, or the latter, was true, that they have a new drug that's half the dose. So the new dose, the correct dose, is lisinopril 20. Oh, okay, thank you very much. Would you like me to inactivate the 40 milligram dose so we don't have to have this conversation again next time? Oh, you can do that? That's great. Yep. I hit the inactivate button, and then I put my credentials in, and then we're good to go. It doesn't show up anymore, and it's inactivated in the system. Super neat. Another kind of thing that doesn't get a lot of attention is OTCs. Now, OTCs have blown up, and we're not just talking about Tylenol, Motrin, that type of thing. We're talking about herbals. We're talking about supplements. We're talking about even things like CBD, which have drug interactions and are important to note. It can be difficult depending on the type of system that you are dealing with. One thing I might ask your preceptors about is this issue. How do you, so let's say the patient's on St. John's wort. St. John's wort is used for, it's off, it doesn't have a label, it's an herbal, but it's been shown to have some efficacy in depression. And so that's tough, because, depression has a lot of prescription therapies in addition to OTC therapies or herbal therapies. So how does your pharmacy, or how does your IPI site note that? It may be something they hadn't thought about, or if they have, they hadn't thought about it in a while. But I think you could learn a lot by asking that question and see what happens. I mentioned MTM there. I won't go too far into that. That's a site-specific thing. But yeah. All right, so we've talked about this in other settings, the 5 rights. We've got right drug, right dose, right drug, right patient, right dose, right route, right time. Those are pretty well known. There is some value in this type of mnemonic, because it allows us, again, to have it function like a checklist. At pickup, when we do the almost inverse of what we've done at drop-off, we're again validating and verifying what we did, which is, I know, sounds kind of crazy, but it's so helpful. So you ask for name, date of birth, phone number, address. You're watching for similar names, date of births. You've got some twins. I remember in a community that I'd worked in back when I was down in Tennessee during my residency, there were like 4 families where there was, and they were all like not related to one another, but they had a pretty generic name. I think it was Jones or something like that. But they all had a kid, and I think the name was like Kevin or something like that. Goodness gracious. We at that time were organized by, the bins were organized by last name. Whew. I mean, we had like 17 stars. Every pickup station said if you get a Kevin Jones, pay attention, pay attention. As you might imagine, there have been lots of incidents where they got the wrong drugs. Now that shouldn't happen if you verify. I do believe their date of births were the same. I don't. If they weren't exactly the same, they were pretty close. But we ended up having like their name have verify name or something like that in it, so that it would prompt everywhere. And we told them we were going to do that so they wouldn't be confused whenever. I tend to tell people if they're like, okay, junior, senior, I'm like, you really want to make sure when you're dealing with this that you are upfront with the pharmacy. You understand this could be an issue. However, not all people are like that. You might have a family member picking things up, and a lot of people just don't pay attention to things. You know, you've met the public. I've been a member of the public. I understand that. I have a little note here to say use any available system flags or hard stops. CVS has a couple different types of these. We honestly don't have a great system for deciding what system flag or hard stop to use. A lot of people just do the hard stop, which is where it pops up with a warning message that you have to hit X to get out of. That can go down. There can be like 4 of those. One time I saw one of them was like, we loaned 3 tablets of this on a certain date. I'm like, give me a break. That's not a real hard stop thing. I mean, I get it, unless it was like something really expensive, but that's not really a hard stop. It's almost like alert fatigue if you do that, because that makes me ignore the next couple, or at least risks ignoring the next couple. So let's say in the example, the confirming allergies, I mentioned the example of prednisone and methylprednisolone that happened on this last shift that I worked. That's a good example of that. Another thing that I found is that patients may not seem like they are low health literacy when you first talk to them, but it comes out very quickly. And so when I'm asking them a question, they look at me, and I know the look. My mom and dad are low health literacy. My mom is a WebMD warrior, but bless her heart, she's just not all there. She tries. My dad, on the other hand, he called COVID Corvus. So he did notice that he was peeing more so than normal, which I guess I'll give that to him. And he called his pharmacist's son. He did not call his pharmacist's son when he started taking ivermectin regularly, however. It's a side story. But you end up finding things out by talking to the patient that you oftentimes did not anticipate finding. I can't remember the last interaction I had where it went exactly as I would have thought it went. Sometimes I would have anticipated interactions be very difficult. They ended up being smooth, fine. Other times, the exact opposite. So be prepared, I guess, would be a piece of advice. Ask, confirm, verify. Understand that you are there to help. That is what you are there for, both spiritually and logistically. All right, key element 2, drug information. So a lot of errors are, it's about 1/3 of preventable ADEs are directly related to inadequate dissemination of drug information to the patient. What does that mean? Counseling. Drug information to the patient is counseling. So either they weren't counseled appropriately or they didn't understand the counseling. The most common cause of med errors, both in prescribing and administering, in terms of the medication use process, is lack of knowledge, especially dosing. Whether that's because of some information issue on the back end, like the weight or that type of thing, not knowing it's a weight-based dose, or something to that effect. 1 in 6 ADEs were related to miscalculations or using wrong units. MG versus MCG, ER versus IR versus XR. Those all seem real similar, but a lot of things in pharmacy seem really similar. Said this to several people over the last 6 months. If you struggle with differentiating things that are very similar to one another, you've got to figure that out, because that is the bread and butter of pharmacy. We get paid the big bucks, quote unquote, because we know the difference between a milligram and a microgram. And we know the difference between an ER, an IR, and an XR. Sometimes they even throw in things like SR. That's why we get paid the money that we get paid. So if you think that that's an outsourced endeavor, meaning like I can either ask ChatGPT or Google to do it, incorrect. That is what you are expected to know and you're expected to do. All right, so some of the factors that lead to lack of drug information, I will just throw it out there. Having not updated natural products references. The studies and things like natural products, I get a lot of questions, randomly. Someone will come up and say, "Hey, does this work?" And it's like some kind of supplement. And the problem with the supplement approval process, you'll probably talk about it in research design, is that it's not scientific at all. Supplements just have to not say that they do things. They don't have to say that they do anything. In fact, they can't say that they do anything. That's why the supplements are just like for the heart, for the brain, for the immune system. What the hell does that mean? Nothing. So, yeah, they'll say a lot of stuff, right? They're like, oh, your immune system is very, very important. Take, take what, I don't know, Sambuta or whatever. They don't have to say that they do anything, and they can't say that they do anything. So special precautions on new medications. So this is an example when a drug gets approved. A lot of times, particularly if the drug had a kind of a lengthy approval process, there'll be some special precautions on it, whether they're initiated by the third party or there's some other else. I'm thinking of drugs, and this is not even just new medications. So drugs like Lamictal or lamotrigine, you actually have a loading dose and like a progression. So you have like a starter pack or starter dose. And then what they're looking for is the potential development of a rash that could lead to Stevens-Johnson syndrome, which we'll talk about next year. I actually teach you about that. So those are things that really, really important to keep up to date on. I mentioned in the, let's see, there's a drug called, oh gosh, it's an antipsychotic, and it causes agranulocytosis. It is, I can't remember the name of it, but it had a REMS program that used to require the patients to bring in their blood work every week, that they had to bring in like their CBC, and we had to have it, we had to do the math, where you had to do, ANC times their percent neutrophils to get their white count, total white count, times their percent neutrophils to get their ANC, and their ANC had to be over a certain amount. Clozapine, I knew it would come to me. That actually changed earlier this year. We no longer have to do that. And so that was a big one. I think the pharmacies were real happy about that. So they sent that out really quickly. But there's all kinds of things like that that happen over time. So, just make sure that your drug information resources are up to date. So there are a lot of alerts that pop up, and sometimes they just don't make any sense. I do hate it. One of the ones that's notorious for me is when a patient is on like a beta blocker for, whatever, hypertension, heart failure, whatever, and they happen to also be anaphylactically allergic to something. The system will prompt and say that's a drug interaction. Okay, theoretically, yes, because that is a beta blocker. And epinephrine, which is EpiPen, that they would use for the anaphylaxis, is a beta agonist, except for that they aren't meant to be used together, and the anaphylaxis induced dose of epinephrine is really high compared to the ability for that beta blocker to block its efficacy. It's more of a theoretical interaction than it is an actual interaction, and you certainly wouldn't not prescribe either of them. So that's just an example, but we do get a lot of alerts, and I've always just cautioned people to make sure that you don't fall into the trap of not reading them and not understanding them. You do understand patterns after a while, like, oh, I know this is going to probably pop with this type of interaction, and you might be right, and that's okay. You need to know what you're going to do about it. It's actually, I think it's really cool when you can start predicting things, because that means you know the underlying interaction that could happen. All right, some risk reduction strategies related to staff. I think a lot of pharmacists don't necessarily do this, and it's not anyone's fault. It's just lack of time and effort and things like that. But educating staff about new drug products coming to market. I've seen, so like let's say I'm reading a magazine and I see that this drug is available in generic. I go to my shelf and it's available there. A patient walks up and talks to the technician at drop off and says, hey, is this drug available in generic? And the tech says, no, or whatever. Well, they're not up to date, right? They're not up to date. So I try to gradually say, hey, you need to look sometimes on these things. That one just went generic. counsel patients on administration and what to expect with the medication. And I think a lot of that comes from the staff being more of a frontline operation. Um, Here, what staff means, though, isn't necessarily technicians. It's everyone in the pharmacy. So I'm going to cover all of the people in the pharmacy when I talk about this. But I think one of the things that people are afraid to admit is that they're scared to either use a drug or take a drug because they don't know what's going to happen to them. I remember the first time I took, oh God, what was it? It was something, first time I ever used an opioid is when I broke my finger in pharmacy school. Of course, right after I learned about all the addiction and all this stuff. And God, I was in terrible pain though. I was terrified. I thought I was going to become an addict instantaneously. And I didn't, but it could have. I mean, it's possible I could have. I just was so terrified. And I was terrified to even ask my pharmacist that I had worked with for 3 years at that point. So it happens to everybody. Double check all calculations. And I actually have usually someone double check mine when I am working. Or if I can't do that, let's say I'm truly by myself, I have actually sent a photo of my calculations either to another pharmacist, or now I can actually send them to Google Gemini, which is my preferred AI, or send them again to like another person. Sometimes I'll go away and I'll come back, and then that gives me a little bit of a cleaner head about it. Review RPH override activity. This isn't that common, but just to see if pharmacists are just going through, I think the numbers games of thinking about like, how many prescriptions have we verified? It doesn't mean if you verify prescriptions at a rapid clip, it's great until you go and you've made tons of errors. There's a balance. There's a balancing act for all of this stuff. I think another, so the green one here, verifying all medications and health conditions. Sometimes I get new information when I go talk to the patient. I have to go add that in before I forget it. So sometimes I'll grab a little sheet of paper and I'll write it down. And sometimes I'll make it under the guise of like writing down their phone number so they don't think I'm like taking notes about their health condition or whatever. But it does allow me to document that I had that conversation. And then again, making sure all references are up to date. Technology-wise, easy access to online drug information. No, most pharmacies don't have an issue with that now. DUR alerts, we just talked about that. Category X, which is not called that anymore, but we're still going to call it that because that's what most people think of it as. That is women of childbearing age or pregnant women. Those are big technology-based alerts that can be over-alerted because what if the patient's not pregnant anymore? Sometimes it is the hardest thing in the world to tell the third party. I've had to sometimes call the insurance company to say, this patient has not been pregnant in 6 years. What is going on? They told me, the specific example I'm thinking of, they told me that what happened was the provider had been billing for dealing with a pregnant woman from a severity code situation because she was still seeing her OB, the one who had delivered the baby or whatever. They were still billing as if she was pregnant, which allowed them to get paid more. Ooh, that was a lot. I had to figure all that out, and I had to tell the patient about it because I had the documentation from the insurance company. Yikes. But that actually makes sense because it allowed them to bill at a higher code even though they didn't need it anymore. We already talked about alert fatigue. Mnemonics in terms of computer shortcuts. I used to have a pharmacist that would have all of these crazy shortcuts. He had one for every prescription SIG code for an antibiotic, a suspension antibiotic had to have shake well and keep refrigerated. Take blah, 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 blah. He would reject it and send it back if it didn't have that. So he came up with his own SIG code, SHWKR, colon, or semicolon, da, da, da. He would document it as an error if we didn't do that. But that is not a good idea. What you're doing is creating inconsistency because the other pharmacists did not do that. And so what we have to do is make sure that we're following the same rules, particularly in a chain format. But I would argue, again, in a setting where you're working with multiple people, you can't operate like an independent pharmacy unless you are an independent pharmacy. That is just the facts of life. All right, talking about 3, communication. So we've got our, classic, this is actually something that was in a magazine several years ago, but, what is this? Written as Prevacid, which I don't really still see the Prevacid. I actually still see the Prenavil. Prenavil is another brand name for lisinopril in addition to Zestril. I still would have filled this for Prenavil. But the key is to call about it. And I don't know, I still go back and just say, what I've called about this? Because I just don't see an A anywhere. I don't see an E anywhere, but I'm just wrong. We don't see as many handwritten copies anymore, so that's great. But there's a ton of stuff out there on the internet about these handwritten prescriptions that just physicians just blah, 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 just scribble it. Our last bastion of that are dentists and veterinarians. And veterinarians, dentists and vets tend to have the same formulary that they write for. Like dentists love Tylenol 3, acetaminophen with codeine. Vets, they'll write for Mobic for dogs and arthritis. They'll write for antibiotics, that type of thing. So that's another one of those errors of like, they don't write for Prevacid. If I was using this, they really wouldn't write for, if it was a vet, like they really wouldn't write for Prevacid either. That's knowing the context is very helpful. So trailing zeros, lack of leading zeros, that type of thing. Those are all general rules. A lot of e-prescriptions ask the prescriber to include the diagnosis on the RX. A lot of Medicare Part D now is requiring it. Medicare Part B has been requiring it for a very long time. They're even so rough that on diabetic testing supplies, we have to send it back to get another hard copy sent over electronically. We can't add it to the prescription. We have to have the provider send in their hard copy if they're KX or KS, which means insulin or non-insulin, and their frequency of testing isn't listed on it. And truly, we cannot add it. So I don't know if that's a good thing or if it's like leaning into the rules, but a lot of providers have gotten wind of it and they start including it anyway because it prevents being called about needing clarifications. But it is best practices to scan hard copies so original is viewed. I'd be surprised if any of you worked in a pharmacy or at an IPI site that did not have a requirement that they scan the hard copy as a part of the system. It's just not that common anymore. Always contact the prescriber to clarify if there's any doubt. There is no harm in doing that. You are the one who has to talk to the patient. Remember that, though. So I kind of use my threshold of like, if it was my mom, would I delay her getting her meds because I'm concerned about it? Sometimes that goes on one side, sometimes it goes on the other. I'm not sure if I would agree to ask the prescriber to use e-scripts. A lot of this is, again, 2009 before the Data Act of 2010, which is what required prescribers to convert over to CPOE. But yeah, if you have a run-of-the-mill doctor's office that isn't doing it by now, they should convert to e-scripts. I was told originally that this looked like me. Not quite sure I agree with it, but there still is the possibility for verbal scripts that we mishear information, so we can mishear drug names that sound similar. You don't have the ability of, or you don't have the benefit of tall man, short man, or tall man lettering, or any of that written stuff when you're hearing a prescription over the phone. And I still do not understand. I took so many verbals on Sunday, why they just barrel through it. They know someone's writing it down. And so I'm just having to sit there and hit one, which is like, go back 5 seconds, go back 5 seconds, go back 5 seconds. Just nuts, like really, really nuts. Missing information left on voicemails, so that they should have put, the worst one is if they don't give you a name or a callback number, because if I need additional information, I have no clue who called. I've seen that a lot. Lately, I've seen like physician parents calling in, from way out of town, and they're calling in, things like antibiotics for a daughter or a son. They're just like, hey, give my baby girl something. And I'm like, oh my God, I have to call them back. One of them didn't leave a contact number. And so I saved the message and I let, as a daughter, I let her listen to part of it. And I said, I just kind of shrugged. And she like, and so she calls her dad and he's like, oh, he couldn't understand that? And I'm like, come on, dude. In terms of the last bullet here, there is always a possibility that the physician staff is also calling it in incorrectly. I have seen that happen more often than I would like to admit. You think that they have all their information together, but sometimes, I gave the example when we first started about, talking about having a senior moment. Just in terms of not having the information that we need when we need it. Sometimes we're given garbage in, garbage out. We're provided with incorrect information. We do the correct thing with it, but the end result is an error. We were just not available or able to do a double check because I don't call back for every issue. Sorry, every non-issue. Let's say it was for one kid in a family. This is what happened. Oh, this is what I was going to say. There was a prescription that came through for there were two sons in a family. One was like 8, one was like 5. They were both e-scripts, but it was where they did a weight-based dose of azithromycin, and the younger kid was prescribed 5.4 milligrams or 5.4 milliliters, and it was the same concentration. And then the older kid was prescribed 3.4 or something like that, or 3.2. I was like, what? Is this kid emaciated or something like that? This doesn't seem right. So I kind of hung on to it. I was hoping that the provider's office would figure it out because it was from a urgent care that was nearby. So I ended up calling and leaving a message, and then the patient came by, and she was really mad because she had 2 sick kids, and I showed her what happened, and she's like, "Well, can't you just fix it?" And I said, "I don't know what they wanted." Now I did actually get the weight and do some calculations on my own. I ended up finally getting in touch with the nurse, and so they called the provider. The provider called me back. They had already gotten off work. They were profusely apologetic, and then I gave them my math, and they said, "Yes, that's right. Thank you so much for catching that. That would have been really bad, potentially undertreating and overtreating someone." But yeah, I mean, it can happen to anybody. So I already mentioned using telephone blanks for prompts, repeating back information. Not as commonly done as you'd like to think. I did a read back last week, and they were like, "What are you doing?" And I said, "I'm reading it back to make sure I had it right." "Oh, okay." I do also spell out sound-alike drug names. So things that are like hydralazine and hydroxyzine. I either ask for an indication first off. A lot of times they'll say hydroxyzine for itching. That's helpful. Hydroxyzine can also be used for sleep or depression. So, or sorry, anxiety. So that's a weird one when someone asks, "Hey, what is this for?" It feeds into the, well, what did your doctor tell you were taking it for? Which seems like it's a cop out, but it really is a way to avoid unnecessary strife. In that case, it was being used for anxiety, so I'm really glad I didn't tell them that they had hives or itching. Listen to voicemail twice. I do this as a matter of habit. CVS allows you to hit 1 at the end of it to repeat it, so I just do that, and I'm just going down the list here. Sometimes I hear things that I didn't hear before, like a frequency and like an indication after it that I was looking. I went ahead and skipped to the refills, and again, because these people are on a race for some reason, they are like, bam, on a race. I don't understand it. They got somewhere to be or something like that. But there's another suggestion. Use IVR that hard prompts the caller. So IVR is interactive voice response, which is when you say press 1 or say 1 for any whatever. You can ask the provider. So some IVRs are so smart that they can detect if a drug name was used, because sometimes they're not really always a prescription. But sometimes the IVR can say, "If you are prescribing a medication, please spell it out." Now, sometimes they don't. Sometimes they think, "Are you stupid?" But there are some IVRs, and I heard about this last year, that detect, using artificial intelligence, if there was a drug name. And it repeats back what they prescribed to the prescriber to make sure that the system heard it. Now, I think this was a gateway to end up having voicemails transcribed for us, like physician voicemails transcribed for us, which is super neat. I don't know immediately if I trust it. I'd like to use it as a second verification. But dang, that's really cool. And then always, always clarify if you had something that's wrong or unknown that was presented to you. So electronic prescription, this is a good example here. So can either be a typing mistake, or sometimes being forced to make a decision can actually be harmful, because let's say that they choose the wrong thing unintentionally, meaning like they meant to, this happens with like formulations of things like cough syrups. Oh my God, awful experience with cough syrups during cough and cold season, because we oftentimes have the brand names don't really exist anymore. We have these branded generics that are like different formulations of the same 3 or 4 ingredients in them. Some have Sudafed, some have like chlorpheniramine, some have all these steroids in them or whatever. And so sometimes if there's an urgent care nearby and I've noticed a couple of prescriptions I've had to out of stock, I'll call them and tell them what we have in stock because I really don't want to have to keep doing that. And the patients don't get relief that day if we do that because they're going to keep sending the prescriptions over because the provider has a formulary that they use in their head. This example here is so Tobradex ophthalmic suspension, 1 drop OD QID. Okay, so that's 1 drop in the right eye QID. Then the special instructions say 3 drops in left ear TID times I don't know how many days that is. Okay, which one of these is not like the others? That's kind of interesting. Like there is a code for left ear. It certainly is an OD. I think that's just wrong that the SIG that is an e-scribe had that in it and then allowed it to get through. But still, I've seen this so often with drugs when there's a new prescriber or even an old prescriber who just is trying to get adapted. They'll pick something. And then in the special instructions, they'll say, sorry, I don't know how to use this. I'm trying to prescribe Zithromax, blah, 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 blah. I'm like, oh my God. Okay. So then I've got to like override it because the computer is trying to find errors for us, which is great. But it is a hassle to have this happen constantly. All right, some of the errors from electronically produced and transmitted, mismatched quantities. So this is a big one because think about this in the form of inhalers because at least our system doesn't make it a hard override. The depending on what e-scribe system that the provider's office uses, there could just be one option for like one package because some pharmacies, let's say it's Advair, for whatever reason, CVS says Advair is 1 dose is 1 unit or whatever. So like Advair, the twice daily for a month would be 60 for 30. It's not that many grams. It's not 60 grams. It's not a gram every time. I don't think it is anyway. But that's just nice and even. Other ones like the ProAir HFA or like the biggest one I remember off the top of my head is like all the albuterol inhalers. Back when that went HFA only, they went back to brand. So like a lot of the brand name manufacturers found a new life manufacturing these branded generics of Ventolin HFA. That had come out of favor when I was in pharmacy school because it was so expensive and we had generic albuterol. But then when they got rid of the CFC containing product, we had to all switch back. And there's not really, it's hard to have generic HFAs. There is a Teva brand, the Teva brand ProAir, but that's a branded generic. So that, if it selects one, is it 1 dose, 1 package? Well, I can't dispense less than a dose. When you get into like birth control, it's a little easier because 1 likely means 1 package, but it does necessitate a call, which is a waste of time when they know what they meant. And the example here is the prescriber selects a quantity of 1 for a 10 ml insulin vial. There are different sizes of vials, so that could be a legitimate call there. Mismatches between drug dose type ordered and dosage units ordered. Solution order with quantity as tablets. Oh my gosh, this happens so much. The prescriber selects amoxicillin suspension and selects quantity as 30 tablets. You've got to be kidding me. The quantity is what dictates how long that they need to take it for usually, even though we can only dispense a full bottle, so we have to round it up typically, and then we have to put discard remainder. But yeah, come on, like double check it. I'm hoping that the systems that the providers are using are getting smarter, just like ours are. I think they are. I don't see as many of these problems anymore, but it's really important that we understand where we came from also. Another issue, wrong drug selected by the prescriber due to stemming, which is enters the first few letters of the drug name at order entry and then subsequently selects the incorrect one. So like if you type in LISI and then wants to prescribe 40, but he prescribes 10 because that's the first one on there. Meanwhile, his eyes saw 40, right? That's our brains tricking us. His eyes saw 40 because 40 popped up on there, but he selected 10 because the 10 was the first thing that popped up. One of the examples here is the prescriber enters MET and then selects metoprolol tartrate instead of the intended metoprolol succinate. I don't love using brand names in the community setting other than for branded products because of these issues, except for here. It'd be a great one. Low pressure and Toprol XL, totally different drugs. One is the succinate salt that you do dose once a day. Toprol tartrate is the tartrate salt where you dose it twice a day. I'd love to separate those on the shelves as far as possible. And we used to, when I first started working, we were sorted by brand. So our shelves were all by brand. So low pressure was far away from the Toprol XL, even though neither of them, actually Toprol XL was still brand for a little bit, but low pressure was not brand. I'd never seen a bottle of brand name low pressure, but it was way far away. Tartrate was way far away from succinate. Wrong drug selected from a drop-down menu of medications listed alphabetically. The prescriber selected procarbazine from a drop-down menu of medications, but intended to prescribe procardia. Same idea. Wrong drug selected because entire medication name was not visible on selection screen, and the prescriber does not the scroll field to read the entire drug name being ordered. Prescriber chooses metformin 500, but intended to choose metformin 500 milligrams ER. Where is that distinguishing part of it? It's way far at the end, and so that could be very tough. And the last one is instructions sent in the SIG field contradict what is sent in the notes field. I already showed you an example of that, so I won't repeat it too much. All right, electronic RX, always clarify. Request clarification for prescribers and educate to say, I saw this that was come through. I don't think this is what you intended, but here was what came across. Sometimes I fax it over to them so that they see what they did, because I made the mistake one time of assuming that they would remember what they did. They don't. They're like, what are you talking about? And then I'm like, well, let me fax it to you. And so now I fax it to them, and I'll say, I'll call them, and I'm like, hey, can you go check your fax? I faxed over a clarification request that I need some, information about. And they're like, oh my, I'm so sorry. That was not what I intended. And it really prevented that from happening. It just saved me a step because I would have had to fax it anyway. And then utilizing computer technology to insert electronic information with minimal data entry. CVS has actually gotten really smart about this. It knows generally what drugs and how they're dosed. And so if in, like an example, SIG code. So let's say that the SIG code for a drug is typically once daily. If it says twice daily on it, it'll pop it up with like are you sure about this? This drug is generally dosed once daily. Like, oh, wait a minute. Wow. Okay. No, thank you. That's really helpful. Hopefully that type of advancement continues. All right. Key element 4, drug labeling, packaging, and nomenclature. So I've got a lot of my own personal examples in this one. The top left, the top right, and the bottom left are drugs in the wild. Not that long ago. I'm not going to tell you where it is, but you can take a wild guess. So yeah, it's not great. You see why they were put where they were put, but there we are. So what I want to do now is take a few minutes and talk about the way drugs are packaged and the way that drugs look, because a lot of generic drugs tend to have the same labels on them if they're made by the same manufacturer. Okay. So example here, clonidine hydrochloride. You see that font, that little like kind of bullet thing around 0.1. That is Teva. Teva is headquartered out of Tel Aviv, Israel, and that's what Teva bottles look like. Aurobindo, I think that's how you say it. The example here is bupropion hydrochloride. That's how those bottles look. They tend to either be bigger or smaller based on the size of the drug and what the quantity is, but that's generally how they look. And this is Hyderabad in India. Going down to the bottom, Amneal, which is headquartered out of the U.S. in Bridgewater, New Jersey. That gray is really what you see there, although some of them aren't necessarily gray, but that gray bottom with, again, like a full circle around the drug dose, the drug concentration or strength is listed there. Zydus, which is in Ahmedabad, India. That's how those bottles tend to look. We tend to see a good number of those at CVS. And honestly, we have a lot of mix of all of these. But I wanted you all to get an impression of what drugs look like, because number one, it'll help you when you're putting up the truck. because when I'm looking for, or when I'm actually looking in the truck to try to figure out what we have, like all the drugs at CVS are just tossed into totes, and so what I do is look up who the manufacturer is because I know what these manufacturers' bottles look like. So, example, that paroxetine 40 there, I can scan, I can do, fumble through it, and I can find all the products. They're made by Zydus, basically. There might not all be what I need, but I know what those bottles look like. Um, the one on the top, Rising Pharmaceuticals, is on the left, Ramipril. That's what those bottles tend to look like. They also make a couple of over-the-counter products like cetirizine and things like that. The one on the right is Lupin, which is out of Baltimore, Maryland. We tend to see a lot of this manufacturer. So their logo is like a weird kind of cactus plant thing, but it is embedded in that green part on the far left of the bottle at the very, very bottom. So, but they actually have the drug name highlighted, and it's highlighted on every bottle. And then they have a different color for each strength. So they might have a red, a blue, a green, a purple, a orange, whatever it was. So they tend to not have the same strength of the same drug being a different color or being the same color. So like lisinopril, it just say this, lisinopril 10 wouldn't be the same color as lisinopril 40. That's good. Viatris, which is a new company that was spun off from Pfizer and Upjohn. They actually took over a lot of Pfizer's brand name drugs. They took over Norvasc, Viagra. They took over a couple of other ones, but this is Nitrostat here, which is nitroglycerin. Obviously, since they owned that product, they just slapped their label on it. So theirs basically looks like old school Pfizer logos, because it is. Camber Pharmaceuticals is in Piscataway. Hope I got that right. Anyone from New Jersey, tell me if I got it wrong. But that's what those bottles look like. And you can see that Camber Pharmaceuticals is right above the drug name. Dr. Reddy's Labs is really old. It's been around for probably almost 50 years at this point, which is a long time in this market. It's in Hyderabad, India also. They just went through a rebranding a couple years ago. They used to be very different. They used to not have as much color. This logo is very different than what it used to be. But it's much easier to see. They designed it using this design first principles about size and where things are and everything like that. Ascend Laboratories in Bedminster, New Jersey, kind of similar to Camber. They have a just kind of like a stock logo that sits above the name of the drug, and a colored version of the logo, or sorry, a colored version of the strength sits below that. Sandoz is the last one there. It is in Basel, Switzerland, and it's a very, very old company. They've been around a long time. They've been doing generic drugs for quite a long time. But they did just go through like a buy, purchase, spin-off thing. But it had such brand recognition among pharmacists and providers that they kept the Sandoz name. So the branding really didn't change. They have a little S for Sandoz in the bottom right corner of the label, which tells me that they love their logo. But it's got like the biggest font is on the top for the name of the drug, and then it's got like it gets progressively smaller. So, all right, I'll give you an example of some labeling gone wrong. So let's go with Kenalog 40. Now, Kenalog is a steroid. It is it's triamcinolone acetonide. So on the left here, we have two different formulations of the drug. One of them is a multiple dose vial that contains a preservative. The other one, so that's the one on the right. The other one on the left is a single dose drug that is non-preservative. It would not be great if you confuse those. I hope you understand why. If I was here in class with you, I would ask you to give that information to me. But in reality, if you assume a drug has a preservative and you act in that way, then you can inappropriately risk contaminating the sample because there is no preservative in it. So what they decided to do after being reported, this was a ISMP alert, and so there were issues with, because these are used a lot of times in like injections, like that orthopedic surgeons do, where they give an injection in like a joint. So that's a really big vulnerability because because you can get fungal infections. That's what happened in, we'll go over it later, but so what I'm showing you there, so on the right, you have the reformulated product. Now, I don't love the new formulation as much as I thought I would. I think they've subsequently made additional changes to it, but I couldn't find an image of it. But this was the immediate post reporting change. And that was, I guess, the easiest for them to do because it just involved making a few changes. What they did was they made the concentration the biggest colored indicator. So 40 per 1, 400 per 10. So that's clear, right? Both of them are 40 per mil, which is what it says on the left, right? 40 milligrams, 40 per mil. So they've already flipped it, and they've said you would have to really try to think that you could get more than one dose out of the left one of the new ones. So hopefully that makes sense. All right, some risk reduction strategies for packaging. Tall man lettering. So on the example there on the right, the hydralazine and hydroxyzine is probably the most clear example of tall man lettering that I can think of off the top of my head. It's Naplex worthy. It's like hydralazine, hydroxyzine. There's like tons of errors that result from it because they're both HYDRO or HYDR, and they were both made by the same manufacturer back in the day, so that's confusing. Using shelf dividers. Now, going back to the photos here, wow, a lot of shelf dividers could be needed here. The one on the top right wouldn't really, the one on the bottom left wouldn't really. So maybe not these, but let's say that Zolpidem 5 and 10, dang if this manufacturer, which is the same manufacturer by the way, didn't just make them the same color. Come on, folks. Like, why would you do this? The only difference is just a slightly lighter tint to the drug name itself. Nothing else is different. Maybe the drug is, the dose is centered instead of left or whatever. I might give them credit to say that the bottle on the right, the 10 milligram, is the older one, since the one on the left tends to have more of the ideal design elements. But I'd be giving them probably too much credit on that. So these definitely need shelf dividers because there's a high risk of error. You can understand why someone would grab the wrong drug, because what if it was on the very bottom shelf? Zolpidem is typically on the very bottom shelf. And they're just reaching, right? They only want to reach once. So if they reach and grab the wrong thing, it's like putting in a USB upside down. Put it in the wrong way, right way. Another shelf label thing is to differentiate between IR, XL, and SLR or SR, or I mentioned like XR formulations with colored labels. And so I didn't include any examples of that, but I've seen pharmacies that will have in between their shelf labels, they'll have like a thing over the head. It's hanging off of the shelf above that says, this is IR, this is SR, this is XR. Super helpful. Seems like it would be like, duh, but yeah, very, very helpful. All right, now we're switching gears to talk about the patient label. So you learned about all this in law, so I won't go over this in detail, but one of the things I will point out that's very, very helpful that a lot of pharmacies are doing now is putting a physical description of the drug on the label. Wow, that is so smart, because the patient is the last line of defense to prevent an error from happening, or a harmful error from happening. And I have had situations in which patients will call and say, it says this is supposed to be a blue tablet, but this is clearly a white tablet. And so I will have them bring it back in, and it'd be the wrong thing. And I'm profusely apologetic about it, and I fill out all the right forms and everything like that, but that tells me how valuable that component of it is. The manufacturer, a lot of that is due to allergens and the excipients that you learn about in compounding, because excipients are one of the things that aren't as closely regulated by the FDA because they're not part of the patent. So some products have similar excipients because it allows the drug to maintain the same formulation, like needing to be in lactose versus something else, or a non-lactose base or whatever. But you find a lot of dyes and things like that that are in certain medications that are very, very specific, and someone can be allergic to that dye. So then it would be very important to know what manufacturer manufacturer it is. I had a patient a couple years ago, oh, this is more than 10 years ago now, who was allergic to one of the blue dyes. It was like Blue Lake 50 or something like that. There was one product of a drug that she took, one manufacturer that did not have that. Guess who was there on the day that they had dispensed the drug to her that had that product in it? Me. And so I had a bit, and I didn't fill it, and I didn't authorize the dispensing. But as you all know from law, you are responsible for every medication that goes out that door. So it was my fault. And so she was a very good patient, very patient with me, both ways. And I was very thankful for her and her patience, because I apologized. I didn't have a way to know it wouldn't happen again, because as you might imagine, that was then the cheapest formulation. And CVS, like a lot of companies, requires you to go around your butt to get the desired product. Sometimes it even causes you to have to submit it 3 or 4 times, credential, put in your blood type, all that stuff. And you'd love to be able to just say she's allergic, but you understand they don't want it. They want to make sure you're doing it for a reason. I just don't think you should have to do it 10 times. All right, so patient labels include the purpose of the medication on the label. So that is not done here. I don't always agree that the purpose should be on there. But I particularly, though, think it's helpful for patients that have multiple drugs that treat the same condition. Let's say that the patient takes 3 or 4 different things for sleep, and they alternate based on, just kind of keeping the randomness going. That would be helpful to know that they're using hydroxyzine pamoate for sleep, or that they're using zolpidem for sleep, or whatever. I already talked about the description on the label. Clear, clean labels. That's what I was talking about kind of a modern label. Use precise measurements. Always use as close to the metric system and as close to a measured amount as you can, versus using something like a teaspoon, or a milligram. Now, there's only a couple of exceptions to that. The brand name Tamiflu used to be dosed in milligrams for whatever reason, and it came with its own syringe. That's how specific they were. And I don't really know if that was part of the approval process, but I remember opening it up and going, it says pull up to 60 milligrams. That's really weird. How could you pull up? Well, it's sure as heck on the label is 60 milligrams. So yeah, the best practices is to use milliliters versus things like teaspoons. Why? Because a teaspoon is a different measurement. Is it high up above it? Like when someone does a teaspoon of sugar, is it like Mount Everest on the top of it, or is it flat? That's a debate for the ages. Barcode scanning, barcode scanning, barcode scanning, barcode scanning. We're going to talk about that with the DSCSA, but dang if that hasn't saved our butts 1,000 times. It saves my butt probably once an hour when I'm working. I try my best to pay double attention to what I'm doing, but sometimes I just get distracted because I've got crippling ADHD, and I go and I grab the wrong dang product off the shelf, and then our system at CVS does not let you get away with not using the one. When you scan an incorrect barcode, it goes, and you're like, whoa, okay. And then everyone in the pharmacy knows you scanned the wrong thing. Okay, I'm sorry. Thank you. I look at what I did. It says scan failed. And then sometimes it's as benign as it's the wrong size bottle. Like I was supposed to grab a 90 and it's a 30, but it doesn't treat that any differently as if I had grabbed, Adderall as opposed to lisinopril. The beep is the same. Imaging. So this is not as common with the 2-step verification for us, because the technicians do the barcode scanning for product verification. Although if the tech bypasses it, they're asked, and there could be a reason to bypass, like their scanner's broken or whatever. They give it to us. They take a picture of the bottle, or they walk it over to us. They put it in a basket, like old school, and then we get to look at the tablet again. So I also, the Schedule II drugs, the narcotics and things like Adderall and whatnot, those do not do the product verification, because I verify all of that product. All right, so I mentioned best practices for designing a medication label. Use explicit text to describe the dose and the administration interval. Give 5 milliliters every 12 hours. That's very specific. Not to say, administer 1 teaspoon around every half day or something like that. That's nuts. Don't do that. Use a universal schedule to simplify instructions. CVS has a dose schedule that I've become really fond of, particularly with things like thyroid medications. I'll get a lot of questions from patients who genuinely want to know how to do it correctly. And so I love that CVS provides us a tool to be able to do that. I'm sure your pharmacies have something similar, including the indication whenever possible, simplify language and use numbers instead of words, because like THREE may be difficult for someone who's an English language learner, but the Arabic numeral 3 is fairly universal outside of certain languages that are either tonal or like symbol based. Use a larger font. That's another thing you'll see a lot more lately, is font sizes growing. So CVS actually had to adopt a whole different standard for their labels based off of a 20 dram vial instead of a 13 or a 16 dram vial, because they redesigned their label to put more information on it and make the font bigger. So that took a whole, 8,000 store company getting rid of 13 and 16 dram vials and shifting over to 20 to adopt this best practice. Using white space and capital letters to draw attention to information. I wish I had a label here that I could show you. I didn't pull one, but if you next time you look at one, look at whether or not it follows these best practices, because I would bet that it probably does. All right, so now we're going to talk briefly about the OTC medication label, because this doesn't get a ton of attention, but we don't always think about the fact that, like, toothpaste, for example, is a drug, particularly things that have fluoride in them, because fluoride is a drug. Like sodium monofluorophosphate, 0.76. That's anti-cavity purpose. So this is 21 CFR 201.60, which is part of the federal code called the Drug Facts Labeling, DFL. OTC drugs must be labeled with adequate instructions for use so that the consumer can use the non-prescription drug product safely and effectively, and self-select and use the non-prescription drug product appropriately. So you want to say this, what's the difference here? That they can use it safely and effectively for the purpose which intended, and that they can self-select it. So is there enough information on there for the consumer, the person who is the end patient or their loved one can self-select the product? Is there enough information? So 21 CFR 211.132 is also part of federal code. It requires all OTC products where they do give an exception to dermatological, dental, insulin, or lozenge product must be sold in what they call tamper-evident packaging, which is defined as having one or more indicators or barriers to entry, which, if breached or missing, can reasonably be expected to provide visible evidence to consumers that tampering has occurred. This does not say tamper-proof, because there isn't anything in the world that's tamper-proof. See any videos of bears breaking into bear-proof trash cans, as case in point. So they've just kind of given up the goat on calling something tamper-proof. They really want it to be tamper-evident. So you'll see a lot of packaging that's like that, where it says, it even says tamper-evident on it. There will be something that indicates that this drug has been tampered with. And so it isn't always obvious what it is, but it is known to the end consumer. All right, so what are the components of a OTC label? So it starts out at the top with the word drug facts, and then active ingredient in each tablet. So that's the main drug. In this case, fexofenadine, 180 milligrams. It has a purpose here, which is called the product, action, or pharmacologic category, typically in patient-friendly terms. Meaning, like, it's not going to have like the long pharmacologic category. It might say something like, in this case, antihistamine. But it won't say, like SGA or whatever. It won't say that, because that's not relevant for the patient. Then in C here, it says symptoms or conditions approved to treat. This is where I draw the difference out between B and C. B is not an indication. B is a category of drugs. And just like we've been talking about this whole time, you can use the same drug to treat multiple different purposes. In this case, though, they're talking about something that the patient can self-select. So they need to know what conditions this patient, they don't need, it's not meant to be a consultation, it's meant to be informative for the patient. Letter D is warnings, which mean, and they're patient friendly, so do not use, if you ever had, ask your doctor, when using this product, stop and ask a doctor if pregnant or breastfeeding, et cetera, et cetera. E is if they can't fit all the information on one line, they have to have an arrow that says where to go next. F is a continuation of the drug fact, so it's got that at the top, but it's the dosage instructions. So it usually talks about either if there's age differentiation, a bottom age, like, so this case, fexofenadine 180, adults and children 12 years of age and under, children under 12 years of age do not use, and then it gives you different parameters. So the adults 65 and older, ask a doctor. That's really because they need more close monitoring with it, and it's not safe for them to be able to self-select and use without monitoring. G is other information. So really it talks about product storage, like the temperature and conditions in which it needs to be stored. Sometimes it actually has other informative information, like an example would be how much calcium, potassium, or sodium the product contains. I've always thought that was interesting because it's not necessarily the active ingredient, but it certainly isn't benign for a lot of patients. H is where you get kind of a list of the inactive ingredients. This is really helpful for allergens, although again, it's patient friendly language, so it might not have all of the information. You still might have to either contact the manufacturer, which is what I is, contact the manufacturer, or contact the distributor to obtain more information. All right, key element 5s, drug standardization, storage, and distribution. This is a messy pharmacy over here. Luckily, that's an old picture. No pharmacies are that messy. I will not read these because we're going to go over them each in detail, but you can see some overlaps here. Using shelf dividers, stocking ophthalmic and otic products separately, stock medications alphabetically, maintain a clean workspace, eliminate chemicals that are no longer used for compounding, store outdated products away from the dispensing inventory, use adequately sized refrigerators and narcotic cabinets. Okay, I hope you're not. I mean, I hope you're doing that. Use a separate refrigerator for stock versus prepared prescriptions and organized pickup bins. These are all best practices. So we're going to talk briefly here again about the Drug Supply Chain Security Act, DSCSA. So originally it was passed in 2013. It was designed to prevent the compounding of a commercially available drug. And an exception was made for disruptions to supply chain, usually back order and drug shortages. It requires distributors to track medications and report to the FDA. It also requires manufacturers provide unique labeling for each medication. All right. So one of the things that I know gets tossed around a lot is this 2D barcode, but I really wanted to just hammer in on what is meant by this. So 2D barcodes to identify fraudulent medications, or basically medications across the board. 2D barcodes are as opposed to 1D barcodes, which are also known as linear barcodes. These are the things you probably are familiar with. The difference here is that in a 1D barcode, all of these lines indicate the number that's below. So this is just a string of one-digit numbers. So 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 0, 1, 2. You could dig in there and figure out which one is which, but the machine, so like a barcode reader, can do that. The 2D barcode, on the other hand, I'll go over what goes into a 2D barcode here in a second, but can contain a lot more data. So the nice thing though about 1D barcodes is most of the time, so this is like either a SKU for an SKU, a system or stock keeping unit, a SKU, or like a UPC for like a ISBN for a book or whatever. It's how manufacturers have traditionally kind of uniformly had it where any store's barcode can be read. So this is how you track inventory. The difference with a 2D barcode is you add in serialization and traceability, meaning that I can add in sequencing of time. So I can add that this lot was manufactured on this date and expires on this date. Then you have another one whose lot was manufactured on this date and expires on this date. This is a little old, but it's actually still true. They did get around 95% compliance, but they still have some areas that are like outstanding. I think they've extended it out to like 2028 now or something. But they're really getting into the weeds of like which drug products are just not commonly used and so they don't manufacture them as much, and so it's hard to kind of like spontaneously manufacture drugs you don't use all that much. So I wanted to briefly go over how the 2D barcodes, also known as QR codes, work. So if you notice, this is asymmetrical here. What's missing from this corner is this block here, bam. So what this does is it tells you what orientation, it tells your phone or whatever reader you have, what orientation the code is. Why is that important? It's because it reads it in a certain direction. It contains so much information that it can't be read in a different order than what it was intended, or it would be gobbledygook. So if you're looking at this QR code from upside down, or this 2D barcode from upside down, and you hold your phone over it, the phone is actually internally twisting it or changing the orientation of it so that it can read it. That's why you can kind of look at a QR code and turn your phone to the side and it still knows what it is. It's not because it's magic, it's because that's what this was designed to do. So that's why it's asymmetrical. These data sections here correct for digits on curved surfaces. So this is just another interesting note here, that there are repetitive sections here that then validate other sections. And so that's another kind of error correction thing, is they say like, hey, did you catch the above one? It said this. If you didn't, this is what it said. And later on, it'll say the same thing. You can put a ton of information in these. They don't always have to have that. If you go through a QR code generator, the more information you put into it, the smaller the blocks will be. And to a certain point, the QR code readers, like your smartphone, can store a lot of information, and it can read a lot of information from it. The data sections store up to 7,000 digits or 4,000 in white squares, which means that you can actually have it to be all, nothing blank on it. You still need a little white, but that it can store way more than what we think it can. Error correction, which is interesting. So I'm sorry about all these misspellings here. This was AI generated, so you can imagine that it doesn't know letters and numbers all that well. But I thought this was very helpful. So like I said, the built-in redundancy, you can't scan either of these. They made that on purpose. But the redundancy compensates for smudges or damage. The software in your phone, that's why I used to have a separate app, and now that they built into the camera apps for most phones, because it is a separate code that deals with all of this information. So sometimes there's a mode on phones where you go right into it. Sometimes the phones auto select, and then sometimes it just doesn't recognize it, so you have to force to tell it it's a QR code. But this is the same as the 2D barcodes for the DSCSA. All right, key element 6, medication device acquisition, use, and monitoring. So I'll teach you about epinephrine and autoinjectors next year, but one of the things to note is that drug delivery devices are not standardized and are sometimes very difficult to use. And so this has been, as long as there have been medical devices, this has definitely been true. Common reasons for adverse effects or errors linked to devices. Number one here is a big one. You didn't include a measuring device. Duh. I can't tell you how often this happens. My sister calls me. My nephew used to take a drug that was a suspension every month, and she would call me and say like, "What if they didn't put the suspension in there? Oh my God, they didn't put the syringe in there. Dadgummit, his dose is like 6.2. She doesn't have that." And she's like, "Can I just measure out a teaspoon?" No. Do not do that. So did you have the old one? Do you have any left over? So she ended up finding one and washing it out and stuff like that. But this is bad, because if we tell them to give 3.8 milliliters, we have to give them something to measure the 3.8 milliliters with. Another problem is that the machines or devices could not be calibrated. You could have unsanitary equipment, multiple types of administration devices with no trainers. Like, you need a trainer for your epinephrine auto-injectors, but some of them don't have trainers. There are no trainers for your GLP-1s. Hopefully the videos and stuff can help you, but if you mess it up, you've wasted a dose, and that's kind of stressful considering how expensive they are. I think, going back to this, the reason why epinephrine auto-injectors have a trainer is because you oftentimes have multiple people that are involved in the care of a child that has an allergen. or has an allergy. So it is really super duper important that multiple people know how to use it. You can't just wait for an allergic reaction to happen either, because it may never happen. Versus a GLP-1 or other injectables that they're going to be administered no matter what. So, and the person is generally going to self-inject it. That doesn't always happen with an epinephrine auto-injector. All right, risk reduction strategies. I can't echo it enough. Make sure that a measuring device is included. I see this all the time at CVS. I will go to the window and counsel, and it will be on. I have to mix it at CVS. The pharmacist or an intern has to mix it. I'll go. I will talk to the patient, and I'll open it up, and I'll look, and there's no measuring device. I'm like, dadgummit. So I go grab one. I explain to how to pull it up, what to do with it. Clean and calibrate your automated dispensing devices. Wash your counting trays. Typically, you should have a different counting tray for sulfa and other like high-risk drugs, and then really educate patients using the teach-back method. I have them draw it up for me if there's enough time. All right, key element 7, environmental factors, workflow, and staffing patterns. So the risk reduction strategies, identifying workflow patterns that present overlap or crossover. If you notice people are running into each other at work in the pharmacy, that is a crossover, an overlap. Provide adequate lighting. It seems pretty basic, but if things are dark, you can't see. Control temperature. I'll probably put that one in there selfishly because I'm so hot-natured. Reviewing prescription volume, which is pretty well done. I actually think that this is less of a problem than it used to be. But I think one of the challenges that just especially chain stores had is that there was a lot of emphasis on volume being a necessity to get more staffing. And so let's say that you are low volume, but you have a lot of like high need patients, like people who just don't understand you're in maybe a low socioeconomic, low health literacy area. That can be difficult to put into the numbers. Provide adequate training for new employees, ding, 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 ding. And then consider the ergonomics. This is a big deal. I don't try not to work 12-hour shifts anymore because I do not have the body that I used to have, obviously. Me being so sick and having rotator cuff surgery. Phone headsets, I see these a lot more in stores. I'm 6'5", so what I do is I stack up 2 baskets on one another, and I put the monitor there because otherwise I'm bent over. My neck is just tilted just slightly, and that for an 8-hour shift will be so painful. The technological environment is a little more nuanced. And so if you don't have an IVR, this is from, again, 2009, interactive voice response. Dang, get an IVR. It is so nice to be able to filter through calls and texts for simple issues. Utilize software to prioritize workflow. I know CVS is really big into this. They have the N key for next. It's supposed to prioritize what is supposed to be next, and it might not be even at your store, which is really interesting. Promoting wellness among your employees. They need to be happy and they need to be healthy to be there, because if they're not happy and healthy, they're not going to take care of your patients. And then have adequate staff to fill in for illnesses and vacations. That can be a challenge, especially during, again, cough, cold, flu season. But we need to staff up during those seasons because not everybody will be able to work all the time. All right, key element 8, staff competency and education. So I won't read all these to you, but these are things that typically have been found when the staff are not educated and brought up to competency. So you end up finding that they're unfamiliar with drugs and devices. They don't know what they're supposed to be doing. They don't know how to track errors or report errors, which is a big deal. They don't understand your culture either. I find this one to be really significant. Technicians are unfamiliar with prescription and OTC drug names. I know when I first started at CVS, there was a booklet that had all the drug names on it. It was sponsored by a drug company, maybe like Teva or something. We don't see those anymore because I guess we just have something to look it up. Again, my pharmacy is organized by brand, so I had to know before I went to go fill any prescription what the brand name was. And it took me a while to do that. Some of the strategies for risk reduction involving education is that new employees should be provided classroom and simulated training, as well as that side-by-side training that is so well known. for pharmacy, that experiential training. I don't know if you all might have had classroom or simulated training before you got into the IPI, but I bet you could tell the difference if you did, or you might have really wished you had. Training staff should be in addition to scheduled staff, so that you can't just put a trainee in place of a scheduled person. CVS is hearing this. You should pay attention to this one. Technicians should be provided with education about how pharmacy should only be utilized in education about pharmacy and should only be utilized in those areas consistent with their knowledge and skills. What does this mean? Technicians should not be counseling patients. Now, do I see it all the time? Absolutely. I still think it's a bad idea. I try to pay attention to it as close as I can, but I'll go into a store where a tech's been working there for 30 years. You would think that they were the pharmacist, and maybe they do know a lot, but they're not the one accountable for everything going out the door. So I try really hard to listen in and not overplay my hand when it comes to, you should need to be quiet on that. Sometimes I'll say like, hey, what was that about? And then say like, hey, in the future, you should really let those people talk to me. I'm just concerned because I haven't worked here a lot, and I don't really know them all that well. So I know you might know the patients all that well, but I don't. And so until we get a lot more comfortable, please refer them to me. It's a good idea to hire certified technicians whenever you're able. This doesn't mean that you have to only hire certified techs, but it certainly makes things a lot easier. Thinking about like in Kentucky, certified techs can't necessarily do a ton more outside of the hospital setting. In Tennessee, however, certified technicians can actually take new prescriptions from providers and transfer prescriptions out to other pharmacies. That's really cool. Training should be an ongoing process to new medications, policies, and best practices. You can use your huddles. You can use like newsletters, things like that. Some chains like CVS, they have like these things called like the hub or whatever that even the techs have access to that kind of go through what the ins and outs of all these different things are, so that you're bringing technicians into the fold. That's, I think, something to think about. All right, key element 9, patient education. Patients can be great advocates for their own care. And we, in fact, are relying on them to be great advocates for their own care. I mentioned before that my dad was one who caught that error that we first started out with. He didn't know what he was doing because I told him to take a picture of his bottle. But when I pointed it out, I said, look at it. And he said, oh, you're right. He looked at it and didn't even know what he was looking for, which again is more like my dad. He's the one who calls COVID Corvus. But they need to be educated and empowered. They need to be educated and empowered to speak up, because just think about it, like you might be intimidated by physicians. I've been intimidated by technicians, like in the example I gave you. Sometimes that they're so pushy, it can be very intimidating. Even though I've been doing this as long as I have, sometimes those interactions feel just as fresh as when I was a brand new pharmacist or when I first started out. They need to be empowered to speak up if they feel something is amiss. Now, you might be thinking to yourself, gosh, they don't need to be more empowered than they are. I disagree. The last thing, I'd rather have a person yell, scream, moan, complain, whatever you want to call it, all day than for them to either have an error happen, get harmed, or die. Just think about that as the alternative. So this lists out some minimums of things that patients should know. One contextual thing that I'm not sure you all have been talked to about yet is why is this like labeling thing a big deal? Because it seems so logical that patients should know what they're taking. That did not always exist. In fact, as recently as like the 60s or maybe the 50s, it was illegal to tell the patients what the drug was and what they were taking it for unless the provider checked a little box on the prescription that said label. Now, when I first started out in pharmacy school, when I was working, actually before then, the prescription blanks in Georgia had the word label on it. And I didn't know what it was. It was never checked. Sometimes it was. It was negated by the OBRA 90 counseling point, because you cannot counsel a patient. You cannot be required to counsel a patient by Medicare if you are not allowed to tell them what's in it. So that was negated by that, as where federal law superseded state law. But it was prohibited for patients to know. So this is why there's such a major emphasis on things that patients should know. And you think about a lot of those older patients may have grown up in that environment. You don't question the doctor knows best. The pharmacist should never question the doctor, that type of thing. That's a pretty good list, a basic list of things that patients should know. All right, I like these. Make sure the vial is large enough for the display in the entire label. Provide patients with brand and generic name of the drug. We already mentioned that. Provide a measuring device and instructions. Counsel patients on possible ADEs and what to do if they occur. Most of them are either call us or call your provider, but sometimes it's stop the drug. Or sometimes, in the case of anaphylaxis, it's administer epinephrine. Provide written instructions to complement patient counseling, which is generally on the leaflet that the patients get, but sometimes that can be written at a level that they can't always understand. Encourage patients to ask questions and call if they have concerns. Use your reflective language. I hope you've all done motivational interviewing now, where you know what that sounds like when you're have that open-ended questions. You're really feeling like making the patient feel like they're part of the team. And then encouraging. This was written right after MTM took a bed, so you can see that that's on there. But this is really just encouraging patients that have multiple disease states or conditions to use the services that are available to them. All right, last one is quality processes and risk management. Once a medication error has occurred, it is important to investigate using the root cause analysis. Remember, once it's occurred, this is in the past, then, God, I'm awful. I shouldn't ever write on screen. To use a retrospective method to determine where in the process the error occurred and what the breakdown in the system was. If individuals make errors because the system allowed them to do so. We talked about this last week, recall, that the individuals make errors because the system has allowed them to do so. Any output of a system was perfectly designed to get that output. In order to promote reporting of errors, you have to make sure that there should not be punitive consequences to the individual. We call this a just culture, which we'll talk more about as the quarter progresses. But it's really important to set a good example also. If you have the ability to talk to your technicians or to other people about errors you've made, you all know that I do this hands down. I hope it's been helpful because I make lots and lots of errors. Last Saturday when I worked, there were 3 or 4 errors, and I don't remember exactly what they were, but I thanked the technician who brought it to me. And one of them was, she was real sweet. She was 18 years old. She was really nervous because she hadn't worked with a different pharmacist yet. And she's like, oh, I didn't know if you get mad at me. And I'm like, oh, sweetie, why would I get mad at you? That made me mad because I talked about this. And I said, I talk about this with the students, that you should not be afraid to bring things up because we are all here for the same reason. Think about that could be my mother, that could be your mother. And so she felt better after that. Another aspect here, near misses should be reviewed as errors. That doesn't always happen, but we know that that's actually one of the NCC MERP classifications, and it's like that for a reason. All right, so I mentioned the 2 types of verifications. So traditional pharmacist only, which can be done as a 2-step process. Pre-verification, or QV1 is what CVS calls it. So that's the data entry verification, and then the production verification. So those are typically what that is. I think Walmart calls it like 4-point verification. I don't know what Walgreens calls it. But it can be done, as opposed to 2 steps, it can be done all at once at the end. But I think I see the benefit of doing it split now, considering how many problems I've caught. Another kind of different type of verification is remote verification. So this is more common in a hospital setting, but it's becoming more and more, it's not in Kentucky yet, but it's becoming more and more prevalent as states adopt more kind of hybrid laws related to either liability or burden of, like where the liability lies. So remote verification would be that the pharmacist does the pre-verification, and then a technician or a machine counts the medication and takes a photo for a pharmacist to review the final product. So that can be done off-site, right? CVS has a little bit of that now. So I mentioned that when you hit the N key, when you're in QV, you might be doing QV2 for a different store. You don't know, they actually don't even have it on the screen that you're doing QV2 for a different store. Sometimes I just know because like the hand that's holding the bottle is not the hand of anyone in the store that I'm working at. But that's allowed. So the Board of Pharmacy allows that to happen as long as there's a pharmacist involved in the final decision. So quality processes, so promoting a culture of safety. Blameless is not the right term for it, but it's really not focused on blame. So do not assign blame to an individual. Maybe an individual was contributory to it. So that's what it means by blameless, is because there's just no blame, even if the individual did contribute to it. Coaching. Oh, coaching is so big. I mentioned before that like I sometimes have to gauge how I approach, the potential for conflict with technicians, because sometimes people have been there a while and they're used to the way that their pharmacist handles it. My pharmacist lets me counsel. Okay, that's fine. So I have to figure out a delicate way to approach it. But that's always a give and take, and that'll be different everywhere you go. If an error reaches the patient, you have to admit that it was an error. You have to disclose it. The patients are not dumb. They know. If you say like, oh my, let me just fix that really quick. You obviously just said you're an error. Like it's an error. Tell them what you're doing. So I'm going to fix this for you, and then I'm going to report it. So I need to grab information off of it. Review and analyze errors to identify system-based causes and facilitate implementation of system-based enhancements. Report and do the quality assurance. A couple strategies that are also in addition to this, self-audits. So one of the things that I'm not sure how robust some of the systems are, but you do have the ability to pull error reports. And I think that this is more typically traditionally viewed as a punitive, like, oh, they've done a lot of errors. And I've seen it used as part of the evidence to let someone go, because it isn't always about the errors, and sometimes it can be just excessive errors, but sometimes it's about the process. They don't care. They're not following the steps. That's more similar to like a 3 strikes and you're out rule. That's also reckless, which is what tort law is based off of. So you could very easily get sued. If you act recklessly, which means you knew better, then you are cruising for a bruising, broski. Staff audits review order entry correction rates. And so at CVS, we can hit R for reject, or whatever. And if we're at a different store, we can do the same thing. It sends it back. That's all tracked on the back end. I don't know what happens with it, but it's part of this audit process. Create monthly action plans, and then utilize computer software to timely identify overlooked errors. Right, so the last little section here is reporting, reviewing, and addressing med errors. We've already talked about this. I won't go into too much detail, but I will focus on MedWatch and VAERS. So this is the hard forms for MedWatch and for VAERS. VAERS has the word vaccine in it. All problems with vaccines, error or non-error, meaning like someone has an allergic reaction from a vaccine, that goes on VAERS. If someone was given the wrong vaccine, that goes on VAERS. MedWatch, on the other hand, is for side effects of drugs. So let's say that this drug caused a person, and I'm just making this up because I'm tired and it's an extreme example. This drug caused a person to burst into flames. That is not a desirable outcome. I'd hope that somebody would report it. That goes on MedWatch. Now, what's interesting is a lot of entities, I guess, have their own centralized reporting that then when you click that it's a vaccine, the internal system starts filling out the VAERS form. And if it wasn't a vaccine, it starts filling out MedWatch. So the problem with VAERS and MedWatch is that if you work for a chain in particular, you oftentimes don't know what you're filling out. But the NAPLEX does, and so you need to know that vaccine stuff goes on VAERS. MedWatch is for all other medication-related problems. All right, the last part here. I will not read these directly to you due to lack of time, but these are very, very important. These are the types of strategies that are effective in the community setting. So the first one's fail-safes and constraints. These are changes to the system or in the design of a product that prevent errors. So this is like a catch or something. Like if you have a backstop or something, that's a physical or logistical change in the system. So the example is a pharmacy computer prevents ringing up a prescription until the final pharmacist verification has occurred. That's exactly what happens at CVS. So they always say, hey, can you QV2 it? And I'm like, yeah, so I do it right then. Forcing functions. So the procedure that creates a hard stop to ensure important information is provided prior to proceeding. I mentioned before that that can be overused, particularly like for random things, like we loaned them, 2 pills or whatever. So I'll just kind of remove those from being pop-ups. Automation and computerization, use of technology, e-prescribing and robotics to reduce reliance on memory. So the example here is true electronic systems that receive electronic prescriptions or robotic dispensing devices. So that is not necessarily over-relying on those systems, but understanding they have a role. What you're doing there is you're trying to put stuff that would normally be System 2, remember, into System 1, except that it's in the computer System 1. I like that. Standardization, creating a uniform model or consistent process to reduce variation and complexity. I mentioned it before and mention it again. Anyone who treats a chain drugstore location as an independent really should have to work all the time at that store and never be covered for. Because if I go in there and you treat it like an independent and you do things in it that we would not normally do, or I don't know about, then I look like a fool, even though I know CVS policy. So standard processes to guide the pharmacist's final verification. So like, what do you look at? How do you look at them? Enhance safety of a telephone medication order. Follow all of the prompts or all the blanks. Redundancies, incorporating duplicate steps or as an additional individual for extra checks. So another one, using both brand and generic names when communicating medication information. I try to do this as much as possible because sometimes, especially older patients, might only know that by the original name they started taking the drug. Neurontin is a good example because it's been around a long time, and gabapentin is a little more difficult to say. So a patient, where's my Neurontin? And I don't know why it's easier to say, but I've seen that one as a specific example. Reminders and checklists, we already talked about this before. Anything that drops out the work in the thought process is a checklist. And so prescription blanks include prompts for medication, indication, etc. Rules and policies. So these are the formal guides, the SOPs that support other strategies, but rely on, so formal organizational guides support other strategies, but rely on memory, meaning that it isn't something that's forced. You have to remember that the policy says or does this. So effective rules and policies should guide staff toward an intended positive outcome. Like if it's like a policy devoted to what you could wear. It doesn't tell you what to wear. It usually tells you what not to wear. And the last one is education and information. So tactics that rely on an individual's ability to remember what was presented, very weak when used alone. So what this means is like if I go through a seminar where I'm learning about how to use something and I never get any reinforcement on it, and I'm expected to use that information only once every year, dang, that's going to be very difficult. So an example, no specific concrete system example was provided in the text and focuses on reliance on memory and individual ability. So where do all of these different interventions stack up in terms of their impact? Well, I kind of gave it away because that was the order in which the definitions were presented. As you might imagine, education, information, rules and policies, reminders and checklists were on the lower end of it. The hard stops, the fail-safes, constraints, the physical stop what you're doing, forces you to stop. What's the example I gave earlier? When I scanned the wrong dang barcode, everybody all the way out to the main entrance of the store knows that I did it. Well, guess who's not going to do that crap again? Or who's not going to let it happen at all, because I know what's going to happen with it. But that's very impactful. Now, if all of the stuff we did was that bad, it wouldn't be great. But you can see how effective that type of thing is. All right, so that's it. I will hopefully be able to be back with you all on Wednesday. So thanks.